Diabetes care, and again, the others on the right-hand side, some of the same ones. And here you see in terms of the HbA1c there as well. Sanford Healthcare is in South Dakota. They make the list here. Some of the others are somewhat similar. Okay, so what we're going to do now, I'm going to call Hector up. He's going to make some observations based on some research we've done around some of what you've just seen, and then we're going to go into the clicker and get a little bit of input from you. Hector.
Thanks, Steve. So one of the things that's clear by looking at these graphs that were just displayed is the breakthrough improvement that Kaiser Permanente, both North and South, have achieved in these metrics. And many of you, I've had many conversations, the team here, over the years, and it's sort of impossible to become like Kaiser for most practices in the state. And so we really need to think about ways that we can learn from Kaiser's breakthrough improvement, but are feasible to implement strategies that are feasible, or bundles of strategies that are feasible for smaller practices, for practices with less quality improvement infrastructure, et cetera. One of the key challenges, as well, as you've probably seen in this graph, is the challenge of HbA1c, or blood sugar control, relative to the other metrics, blood pressure and LDL control. And we have to take a step back as a state and understand how to think about this, because we clearly haven't seen breakthrough improvement in glycemic control. And think about trade-offs for patients, and especially for patients with multiple chronic conditions who may prioritize other measures other than blood sugar. So we need to think about collectively whether that's an important measure for us in this initiative, and if it is, how to foster breakthrough improvement on that measure. In order to get a sense of who's in the room, this is just a practice thing to see if the clicker system is working, but also good to know the distribution of stakeholders in the room today. If you could mark which one comes closest to which sector of the healthcare system or health sector you belong to in terms of your organization.
The clickers are in front of you.
Oh, sorry about that.
The letter that corresponds.
Yeah, you just press the button of your response.
No hitting enter. You just hit 1, 2, 3, the number, and then you should see your answer.
A through J, one of them.
So when we get to about 100, we'll stop voting.
How many do you have? 95. So it shows you here up here on the
Yep.
right. Come on, voters, vote.
We won't go to lunch until that last person.
No lunch for that person.
If you voted, click again. Make sure if it came through.
Steve, did you vote?
There we go. All right, we can close it now.
Oh, I didn't know.
Here, you just voted for you.
So as you can see, we have a strong presence from health plans and insurers in the room, followed by other organizations as well as physician organizations, both integrated groups and IPAs. But interestingly, we have representation from all across the board here. So what a special treat to have multi-sector collaboration in this room.
Are both physician organizations. That is the largest group here.
Great. Next slide. So I mentioned, as I tried to summarize a few of the points, that Kaiser Permanente, as we saw from the graphs, LDL control and blood pressure control, there's breakthrough improvement that continues to improve. It sort of defied some of the odds we thought. We thought there might be a one-time bump with flattening out, but Kaiser's sort of demonstrating that continuous improvement is possible. I'd like you to vote in terms of thinking about the rest of California, non-Kaiser. To what extent are the Kaiser Permanente improvement strategies, we're talking about bundled medication management, use of care team approaches, structured follow-up of patients, will these be applicable in managing cardiovascular and diabetes risks and conditions in non-KP settings? If we were, as a state, to provide extensive support to implement those same approaches as Kaiser Permanente, would that be worthwhile? Would these approaches work in these systems? And you all voted, so you all have an opinion, so I'm going to cold call on individuals. And we'll ask the KP people first.
We need 8 more.
All right, we'll stop at 92. I won't do this. All right. So most of you, the majority of people in the room, but just barely, think that these approaches will apply to other settings as well. I'd love to hear sort of feedback as to why that is, but some think it's only somewhat applicable to non-KP settings. Love to hear feedback on what aspects of Kaiser Improvement's approach may not be applicable, might need to be adapted to other settings in order to work. And see, maybe a minority, 1 in 10 people think that these approaches, team-based care, medication management, may be too resource-intensive or require too much infrastructure for other types of settings. So anybody want to volunteer their perspective about, let's start with very applicable to non-KP settings. Why would these evidence-based approaches that Kaiser has used be just as effective or work in other settings? Anybody willing to volunteer? Yes.
I think it's, one of the speakers said there's no magic bullet, it's just doing ordinary things consistently.
So these are strategies that need to be bundled, and it's about execution, and so it's not a fault of the strategy, but it may be an implementation challenge that needs to be overcome. How about those who think that this is a different ball of wax in other non-KP settings, that the things we need to do to move the needle on these metrics is different, looks different, feels different, etc.? Yes?
Say who you are.
If you could say who you are, that'd be great.
Andy Pomerantz, I'm the Executive Director at Western Diabetes Institute, which is an integrated practice unit in Pomona, California. I think the challenge outside of Kaiser, because we deal with the non-Kaiser world, is the healthcare ecosystem for each patient. We have patients who have maybe 12 different providers, 3 different health plans across their ecosystem, and there's no interoperability of data sharing and actionable data. There is also no interface between health records, whether paper health records or EHRs. So therefore, team-based care and everything that Kaiser can do internally cannot be done outside of Kaiser without new technology. So really we're faced with creating an IT platform that connects outside of interfacing health records and kind of allows people to use mobile devices to connect and talk and share and in real time. And I think that's kind of what's needed.
So you think information exchange is a foundational requirement of team-based care or medication management? Absolutely.
Teams are not just a collection of fragmented services. They function as teams, and there's a learning positive feedback process that has to occur for that to really get to a value-based care delivery.
Great. That's a great perspective. We're going to unpack that a bit more in the next couple of slides. Now, thinking about some of the innovations that have been happening around the country in smaller, under-resourced, or limited infrastructure practices is sharing resources. For example, sharing a pharmacist that would work a day a week in the clinic. Our shared resources, either staff or arrangements in terms of agreements, in terms of shared resources among practices with limited care management infrastructure worth testing as a way to improve the management of cardiovascular disease. What we know is that the non-KP health plans contract with smaller practices with less infrastructure. And so what this really means for insurers is that they have to work with these small practices in terms of improvement. One pathway might be shared services. Is this something that appeals to folks in the room as a very worthwhile thing to test on a small scale, test for a state in terms of shared resources? Is it somewhat worth testing, or is shared resources infeasible due to logistical challenges? So we're trying to find the path to improvement for those practices that have less infrastructure, different than Kaiser, for example. We have 75. All right, it looks like we have diminishing returns here to involvement. All right, we'll stop here. Very interesting. You guys mostly think that this is worth testing. Let's hear why this makes sense or doesn't make sense. Anybody willing to share their perspective about this? So as a state, we should try to stimulate shared resources somehow, get foundations to sort of fund the innovative use of shared resources, etc. Anybody? Parag Agnihotri?
Dr. Agnihotri helped us start the Sacramento University Best Practices and is a CMS Innovation Advisor.
Thank you, Harry. Good morning. And so, Hector, I think, it depends on how the question, if you go a little bit more deep dive. The concern I have, I was the one on B, the 22%, because if you think about it, we have, for years, have had, disease management companies outside which, you could basically purchase those services. But what we have found is that the case managers or disease managers have to be as close to the physician practices for really effective intervention. So I don't know how you plan to share the resources, but if they are just providing advice on a phone and not integrated into the same electronic health record and closer to the physician, the effective of patient engagement goes down,
Yeah, so Dr. Agnihotri brings up a very good point that the shared resources can look and feel very differently. It might be a 1-800 number or a disease management company who doesn't have any physical presence in the clinic, or it could be sharing an individual team member across practices. So I think point well taken that it really depends on the nature of the shared resources. Moving on, Dr. Shortell?
Yeah. So the next one we have is this it here?
Just go forward.
Yeah.
Forward. You're going backwards.
I am going backward. Anybody want to revise their response? Okay, so here we go. To what extent here in California do you feel we face unique challenges in improving the HbA1c levels among diabetics compared to other states? In other words, as you look at the demography of our state, its size and so forth, are we so unique or different that we have some quite different challenges compared to other states? That'd be A, response. B is they're really similar, maybe not identical, but similar as other states, but the challenges are larger in magnitude, or you may have another response. So push A, B, or C. We got to get to at least 90, okay? Okay. Now we're going higher even. Okay, so let's see what that looks like. What do I press? This one? Okay. Did that work? Oh, there we go. Oh my God. Okay. Clearly we're confused. Okay, so I want to ask those of you who said that really we...
Is it an error?
Oh, right, yeah.
Okay, we're going to revote.
Yeah.
Hold on a second. There we go.
Do you have it?
And populating.
And just press the middle.
Yeah. Okay, revote. Right, okay. Here we go, okay. So 58% believe that greater magnitude, but not all that different from other states. But nearly 40% believe we have unique challenges. Those of you who felt that, maybe one person, what do you think makes our state quite different from other states on this particular issue? Yes, Palo Alto Medical Foundation. Sir, right there. Yep. Microphone's coming.
I'm not from
Say
Palo-
your name.
Yeah,
and-
I'm not from Palo Alto Medical Foundation, but my name is Bob Beltran. I'm the Senior Executive Medical Director at Brand New Day. So our diversity makes us unique. Our Latino population, probably the largest in the country, and that in itself presents unique challenges. Many of these folks will go back to their mother country, Mexico, for 3 months, and we can't find them to do the appropriate follow-up. And if you look at health disparities in our state, we're one of the leading states that is challenged with those issues. So, California has always been the bellwether of change for our country, and that's what makes us unique. I mean, look what an advanced managed care system. Look what's happening in South Orange County with the consolidation, the medical foundations, some of the crazy changes that are happening in healthcare that are, I think, very unique. And so I'm puzzled by the fact that so many folks responded to B.
So thank you. Let's hear from somebody who feels that we face similar challenges, although maybe of greater magnitude. What would your response be? Yes. Martha.
I voted B because the challenges are larger in magnitude based on our aging population and the demographics. California has one of the fastest growing aging populations in the country and the largest growing population with Latino aging. So I think that our aging population is facing multiple chronic conditions, diabetes, heart disease, many chronic conditions, and those are larger in magnitude than other states.
Okay, so clearly one implication of this is how do we adapt, right? Context is everything. So how do we adapt to our Latino population, some of the issues that you talked about as well? So we need to be creative. And one of the challenges is you kind of talked about California exceptionalism. Okay, we can call it that way. We're very proud of our state, and you use the term bellwether. But if that's the case, why aren't we more exceptional? Why aren't we more exceptional? Why do we have only a couple of our health plans at the 90th percentile? So we'll talk more about that. Okay, next one, very quickly. Of all of the emerging interventions, et cetera, cardiovascular diabetes risks and conditions, where would you put the main priority? This is a difficult one. The main priority for collaborative practice-based research to test on a large scale. Pharmacist integration on the care team for medication management. Now, I know all of you will say, well, didn't you just talk about packaged interventions? You would want to do all of these? Yes, but we're forcing you now against the wall and say if you had just, $100 to spend on one of these, where would you place your bet, right? So would you place it on the pharmacist integration? Would you place it on community health workers and peer educators for self-management support, or remote monitoring? Or the bundled medication protocol, or something else. So this is difficult, but where would you place your bets? A, B, C, D, or E? If you want to vote, you can do it.
And if you're resisting to choosing, you can choose E, other, if you want all of the above.
Oh, yeah. Oh, now they'll all go to E. Oh, yeah.
Well, okay, forget it. I was hearing disgruntled people who liked package innovation so much, so stick with Steve's direction.
We're just trying to force a little bit among priorities. So you could say, yeah, packaged innovation and intervention, absolutely, but within that, how are you going to allocate the budget? How much to the pharmacist? How much to developing medication products? So you can still look at it that way. So it's a package, but within that, how would you allocate the budget to the package? So given that, Hector and I work together like this, back and forth. He corrects me all the time, deservedly so. So what's it look like?
Good.
Well, I better press this. Okay.
No consensus.
Interesting, yeah, yeah. So somewhat of a nod to the community health workers and peer educators, okay? Those of you who fell in that camp, very briefly, because we're cognizant of time, why did you vote that way? Yes?
As a pharmacist, I voted B. And I lead
You have much more
a
credibility
team
now.
of pharmacists looking to be on the care team. But I think until we have, especially in our state, we have community health workers who are health literate and peer educators, the pharmacist work can't be done. So I believe in bundling all this, of course, but I think we've got to get down to patient activation and patient engagement, and until we get down to the community, we're going to have a difficult time doing that.
Interesting. So the other tools, in effect, aren't going to take hold unless you get that foundation. Okay. Interest of time, we're going to move on to the last one. Which collaboration strategy here should California use to emphasize reduction of cardiovascular risks and better manage the conditions for high-risk heart attack and stroke? So regional collaboration, which has been our model for years, starting with the leadership in San Diego, University of Best Practices, spread to Sacramento, spread to Los Angeles. Cross-state learning collaboration, not just regional. Technical assistance to practices with low performance. And collaboration shouldn't be a strategy we emphasized. It's too hard, takes too much time, takes our eyes off the ball of what people can do on their own. So that's a possibility, or other. So what would be your favorite approach there, bringing your experience to bear? A, B, C, D, or E? I'll turn to you quickly at the end to see if you want to make a concluding observation, if you want to think about it. Yeah, good. Okay, yeah. Okay, we're getting up to 90. Okay, push that. Okay, interesting. So the regional collaboration, clearly the winner, combined maybe with some technical assistance as well. And so anyone in A category, why you voted for that? Maybe you had experience in terms of the learning that occurs regionally that would be difficult to do statewide, perhaps, because we're such a large state. So regional might make a lot of sense. Anyone want to speak to that? Based on your experience, or any of you that have participated in some of these University of Best Practices? Okay, Jim?
Experience we've had, and this is a nod to Jerry Penso, to Maria and other people in the room, and I'd ask them to speak also, is that by working together, we broke down barriers, and by spreading best practices, I have learned tremendous things from our partners, SHARP and UCSD, et cetera. Unbelievable, and you have regional barriers, and you will deal with regional barriers at the same time as dealing with the systems that Phil mentioned, which of course are and you mentioned, which are key.
Very good. Thank you. Okay. Thank you, Hector, and for all of the participation. And just a couple of things. In your small group breakouts at lunch and throughout the rest of the day, some of what we have up here, you'll have a chance to really discuss some more and some of the implications as well. The other thing I would say is that Hector, myself, HSA, Coalition, Hattie, a lot of people here in this room have a grant currently under review that we hope to learn about next November, or this coming November, to try to implement some of the things that we've talked about here in the 6 or 7 counties in Northern California surrounding Sacramento, doing a deep dive, working potentially with about 900 small and medium-sized physician practices to try to get them to where Kaiser Permanente is now, using some of the various strategies we've talked about here. We have no idea whether we'll get that grant. If we don't, we'll continue to plug away to see what we can do. But if we do, it's going to really jumpstart a lot of what we've been talking about. So with that, I'm going to transition very quickly to our panel that will continue to drill down on some of what we've been discussing. And brief introductions, the panel is going to be led by Jerry Penso, And Jerry, as you know, is the Chief Medical and Quality Officer for AMGA, and before that, he led Sharp Healthcare in San Diego. Kendra Gaskins is Director of Measurement Up and Down for the campaign and chronic care initiatives at AMGA also. And then they'll be followed by John Cuddebuck, and John is the Chief Medical Informatics Officer at AMGA and also Ancita LLC. So Jerry, I'm going to have you and your panel come over here. We'll get set up, and we'll go from there. And then that will be followed at 11:25 or so by a panel on control strategies that will be led by Dr. Agna Hotri, and we'll have Lori Arnoldson and Betty Sedler also involved on that panel. Jerry, it's all yours.
I'll never forget the excitement and passion in the voice of Dr. Rob Brenner, who called me about 2 months ago. And Rob is the Chief Medical Officer of Summit Medical Group in New Jersey. And he had called me to tell me that they had improved blood pressure in their group by implementing Measure Up, Pressure Down, our program, from the low 60s to over 80% blood pressure control in 8 months. I'm here today as the Chief Medical and Quality Officer of the American Medical Group Association. We're a trade association based in the DC area, and we represent over 430 medical groups, IPAs, and other organized systems of care. And those groups contain 150,000 physicians, and they ultimately take care of 120 million Americans. AMGF, the foundation, is the nonprofit arm of AMGA. And our mission is to support these medical groups and IPAs and other systems of care in improving the quality of care that they deliver to their populations. The Summit Medical Group that I referenced that got great results is part of AMGF's chronic care campaign. And this is our biggest initiative to date in order to reduce the burden of chronic illness in our populations. The campaign's first target is high blood pressure, and the national campaign is called Measure Up, Pressure Down. This 3-year campaign's primary goal is to get all the participating groups to get 80% of their patients with blood pressure under control, and by 2016. Today you'll hear from Kendra Gaskins, and Kendra is our program's director and our director of chronic care initiatives, and she will talk to you about the program's accomplishments to date. You'll also hear from John Cuddeback, who's our CMIO, and he'll discuss campaign metrics and some very provocative and interesting analytics and discoveries that we're making from the campaign. You'll also hear, and I think this is one of the highlights as well, from 3 AMGA member groups, both within California and from without California, who've dramatically improved blood pressure control in their groups. So I hope you're now curious about what it takes to replicate these results and get dramatic results at your locations. As you hear each of these speakers today, I want you to think about an important topic. I want you to think about motivation. Creating an environment in which physicians and care teams choose to engage and bring their very best is what we need to create a better healthcare delivery system. To improve quality in our complicated healthcare delivery system, it takes many individuals, and we heard about them, the physicians, the nurses, the pharmacists, the care teams, the patients, of course, all working together to make healthcare better. And the question I want you to ponder is what motivates and sustains all these people to do the hard work, to create the innovative solutions, and to be persistent despite these numerous challenges in making healthcare better. So motivating human behavior, I believe, is at the core of success whenever change is needed. Self-determination theory states there's 3 basic human drives that sustain our internal motivation: mastery, autonomy, and relatedness. And to these three internal drives, many have added a fourth one, which is purpose. And I think motivation, this critical internal driving force, is what we need to learn more about so we can improve healthcare. So let's look at each of these drivers of healthcare, drivers of behavior: mastery, autonomy, relatedness, and purpose. So first, mastery, which is the desire for competence and a desire to learn new skills. And in order to achieve better blood pressure outcomes, clinicians, care teams need to learn new ways of doing things, new ways of practicing, and figure out how to embed these practices or hardwire them into their groups. Leaders tend to thrive on mastery. It seems to have emotional, intellectual, professional rewards. And we've seen this sense of mastery demonstrated in what we call AMGA success stories. These are the groups that are achieving high results, like Premier Medical Group in Pittsburgh. And their leader, Frank Colangelo, is now recognized not only in his local community, but within the Measure Up community, and probably soon nationally, for improving blood pressure 10 percentage points in 1 year. Second is autonomy, that sense of choice or control we have over behavior and goals. And I want to emphasize that autonomy is different than independence, which means you can do anything you want. Most of us realize that practicing medicine, we have a lot of constraints based on our systems. Yet successful organizations seem to have found a way to support autonomy, individuality in finding these solutions. As an example, the University of Utah has designated local medical assistants to become hypertension champions at their locations. And these medical assistants have an elevated role doing testing, training, coaching of other medical assistants to improve their accuracy in blood pressure management. The third driver is relatedness, or that sense of belonging or attachment to other people, in this case, working towards a common goal. Human beings have a strong need for relationships based on trust and respect, and leaders in improving care know this and value their role in their groups, and they build trust through authentic and consistent communications and actions. Many AMGA groups, like Summit Healthcare, like Summit Medical Group in New Jersey, like Baton Rouge Medical Clinic in Louisiana, produce what are called transparent physician performance reports that identify how each physician is performing, and they publicly display them, some of them even in the waiting rooms, so that all the patients and the care teams can see how their physicians are performing on these individual measures. Now, if this is done in a supportive way, these transparent physician reports can create a sense of community, if you will, a sense that we're accountable to each other and that we're all working together to improve care. And finally, there's purpose. Purpose is that higher calling that can unite and inspire us. Most of us choose healthcare because there's a strong sense of purpose and desire to be of service to our patients. Improvement programs that really resonate revolve around these patient need issues. And they tend to resonate not just with the minds, but with the hearts of our physicians and our care teams. Frank Colangelo, who I mentioned before, said, quote, "It's in our culture to do what's right and best for the patient." I'd like to read you a letter from a breast cancer surgeon from Baptist Medical Group to their CEO. Now, this surgeon was very reluctant and hesitant to do blood pressures in their office. They said, "It'll slow us down. They're just surgery patients. Why do we need to do blood pressures?" So it was addressed to Jim Boswell. And it says, "Jim, just a note to say kudos to the Baptist Medical Group referral system. I saw a patient today with breast cancer who also had